My name is Deborah Rosansky. I forgot to introduce myself. I'm a director and head of health and social care at OPM, and I'll be trying to keep things moving this morning. And instead of introducing all of the speakers, their bios are in your packs, but we're going to start first with AimieChapple.
Yep,
AimieChapple from Accenture. Over to you.
Great. Well, good morning. It's really nice to be here with you this morning, and I'm going to try to keep us at pace so that we can be stimulated in the discussion. This is us. You can see us. What we're bringing to you this morning is really looking at some technologies that we think will be really important in underpinning transformation. What I'm not going to do today is go through each of those technologies, explain what they are, and do all that, but we're going to try and tell you a number of stories to bring them to life. So, when we look at these technologies that are up here, and we'll come back to them throughout, most of these things exist today, right? And some of them are emerging, and in the pack, when you read the paper, you'll see some things that might be interesting to go and explore and follow. But what we want to do today is to talk about how we can drive patient outcomes, public health outcomes, by using these things better, using them at scale. And where we're going to start is actually, I'm going to have Bridget tell a story about what's happening today as we look at what's going on in the NHS. So, Bridget.
Okay, thanks very much, and good morning, everyone. So I'm the Chief Executive from Airedale NHS Foundation Trust, and those of you who don't know where it is, it's in West Yorkshire, and we serve a population that covers part of West Yorkshire, part of North Yorkshire, and part of East Lancs. Varied population, which includes inner city into Bradford, leafy suburbs of Leeds, and the rural deprivation up into Craven. So that's really where we are. Yeah, thanks. What I wanted to just talk to you about is how we've been using technology and how we want to take that forward into a future state for the whole health and social care economy that we're working within. And this is just Jeremy Hunt came up to have a look at what we were doing, and that was his tweet, which we've been dining out on for quite a few weeks since then. Thanks. So just really briefly, how we got to where we are today. We started off in prison healthcare and noticed that there was a real gap in the market there. Patients having to be taken into hospital settings when either they had some accident or they needed an outpatient appointment, and huge transfer costs and a huge amount of disruption to both the prisoner and the hospital services they were going into. So we started off with video conferencing actually into a local prison and through into our A&E department and outpatient departments. We've now expanded that out over the last 8 years into 20 prisons, and we can provide care across 21 specialties and accident and emergency type care advice across that setting. And what we determined from that was there was a 50% change in patient flow. So about 50% of those patients didn't actually need to come out of that prison setting with the advice and guidance from the specialist expertise. So we then thought about, well, you know, what if we start to think about mainstreaming this? And that's what we've been on with doing over the last couple of years or so. So we've now got telemedicine going into patients' own home, and essentially it's video conferencing. So the technology's there, it's been there for years, you can use different media for it, moving on to tablets, even moving on to iPhones. But we've also got technology that older people can use using a set-top box that they plug into their TV. Really simple console, red button on, green button on, red button off, and a little arrow so they can scroll around the menu that comes up on the TV. So we've got lots of different ways of using the technology that can be friendly to the people who are using it. So caring to patients' own home, mainly around long-term conditions. So we now do it for diabetes patients, COPD, Parkinson's disease, and about 100 patients locally are using this system. We had a bit of a light bulb moment, really, because I was trying to do the financial modelling around it, thinking around, well, how could we get better bang for the bucks, really, with the technology? And started going into nursing homes about 18 months ago, big scale, certainly locally to start off with, and the financial modelling works much better when we use that kind of deployment. So we've now developed within the organisation what we call a digital hub, which is staffed 24 hours by specialist nurses who have got either a critical care background or advanced practitioner type background. who receive the call through from nursing homes, receive the call through from the prisons, receive the call through from the patient's own homes, and can often give advice, and that's often enough to actually stop the patients from having to be brought into A&E or another escalation of care. They also have access to specialist opinion within 20 minutes, so we can put it through to the acute physicians or the specialist within that time scale. So we've been doing that locally in nursing homes, and doing the evaluation of it. It's absolutely enormous, the changes that we've been able to demonstrate. So 69% reduction in A&E attendances from those nursing homes, 45% reduction in admission into hospital beds, 30% reduction in length of stay when patients are admitted, because you can actually discharge them home more quickly. So the benefits are huge, and now we're starting to deploy into nursing homes across East Lancs. Some are going into Birmingham, across the country now, because actually once we've got this evidence, it's starting to demonstrate some bigger efficiency savings. Also, there's applications with end-of-life patients, hugely welcomed actually by staff, and we link through to hospice care as well on that one. So, what do the patients think of it? The evaluation we've done of the patients, broadly, mostly patients really like it. So, huge buy-in from patients. They actually like the fact that they can be more in control and more in charge of when they need to get help. They can get help when they need it, and when they've got a problem, they can actually get the problem solved rapidly by getting through to an expert, instead of, being put onto a very laborious pathway and, having to wait quite some time before they get the problem solved, and also having to be, taken into A&E or attending GP surgeries. So the other thing that we've been developing is with TPP, who have got the primary care system in all of the primary care practices locally. We've been developing with them a secondary care application over the last year or so, and we are now I think the only health economy where you've got access to a single patient record, and it is one record. So as the patient, and we're moving towards electronic patient record within the hospital setting as well. So at the moment, if a patient gets admitted, you can actually see their history, their drug history. Any of the consultants at any time can look into the patient record, and it's making huge changes in how we think about patients, how we manage patients already. So what we, clearly all the challenges are well articulated now. We've all heard about those earlier today. And so using the learning from this technology and thinking about, well, how do we create a future state that's actually sustainable, one that puts the patient in the centre, and one that develops a different service platform really for patients to use, one that isn't based on just the traditional methods of working, but one that is new and more responsive. And what we want to produce is this system that is a 180-degree turn, that's what I call it, because it's about turning the whole thing on its head. So instead of the patient moving around the system to the experts, you actually endeavour as far as you can to keep the patient in their own home, using technology to monitor the patients and to bring the expertise to them as and when they need it. So this is what we sort of tried to draw together, what a future state should look like, and hopefully this cartoon tries to articulate a fairly complex set of thinking into one simple diagram or cartoon that we can follow. So you can see there the patient is right in the middle in their own home, and that thing they've got in the hand is meant to be a conductor's baton. And so we're moving towards patient-orchestrated care instead of it being organisationally determined care. So the patient is the person who determines what the care should be. You can see there they're surrounded, of course the care in whatever setting has to be compassionate, empowered, etc. But the word that we don't often use is the active word. So part of what we want to develop and move on further with is the patient becoming much more active in their care. You can see around the outside of that cloud and the 24-hour support to the patients. The leader of the local council calls that the big hug. It's actually the integrated care that sits around that. And we're doing quite a lot of work locally about integrating health and social care, but we all think that won't do it. That won't really deliver the change that's required within the resource envelope that we're all facing. And actually, we need to have this much more transformational change. I think integrated care is great and it's a great platform, but unless we change how the doctors work and certainly how primary and secondary care work together, the patients, whenever they hit a level of risk, are always going to go into the default system, which often is into A&E. And what we want to do is turn this round so that the default position is the patient's own home. So you'll see on this diagram, there's a myself menu, and really moving into self-care. We've got some evidence locally when you move into care planning, a more proactive way of care, of determining care, particularly with patients with long-term conditions, frail elderly working with carers, patients with dementia. You setting goals that are pertinent to that patient instead of clinically determined goals. It's actually goals that are determined by that patient. So we're moving to this arena where the GP can prescribe for the patient this self-care approach. You can either do it on paper, but there's now a technological way of doing it as well. So patient sets their own goals, could be with the GP, can be with probably more likely with a specialist practitioner, because it takes about an hour to set these goals. And then there's a plan that gets determined, and some of the interventions will be patient-led, some of the interventions are medically led. And then when they're on either on the self-care technology or linking into System 1, or the both, because one is embedded into the other, their progress can be tracked, and it can be tracked in real time. And as you know, at the moment, a lot of what we do when looking at NHS data and patient-level data is about 6 months out of date by the time it's been analysed and we've looked at it. With this methodology, linking the myself menu into the patient record, the real-time patient record, you actually get real-time data. And so what you can then get is feeds out of this into, what we've looked at is how the patients can go deteriorate and enter a position of crisis. Actually, if you look back upstream from that, often you see the biochemical metrics are going off quite a bit before that. And actually, if you look back upstream from that, the behaviour is changing. So what we want to be able to do is to intervene when the behaviour starts to change. So if the diet is going off, exercise going off, alcohol consumption is going up, etc., those kind of things. If you can intervene quickly when the behaviour is changing, you can actually prevent the biomedical markers changing and then the deterioration into crisis. And we really want to try this out in our local health economy using this real-time information, so it's actually real-time live about the patient. And the other thing is around working with the patient, providing them with the information as and when they need it. The patients can connect to each other, so you can develop a social network of patients with similar issues. And in addition to that, you can start to look at the population in units of one. That's how we see it. So the care needs to be built up from units of one, using the real-time data so the care is actually absolutely bespoke around those patients. But also we can look at the aggregated, anonymised data to look at disease patterns as well. So in addition to being able to look at individual patients, we can start to look at actually what works and what doesn't for patients, particularly with long-term conditions, frail elderly, those kind of things where the interventions need to be much more collaborative, much more softer in a way. So to me, that's about populations, unit of one. One of the big areas that we're working on is closing the gap between primary and secondary care. So you can see using digital technology as a platform for communication, it's about closing that gap. We've done quite a lot of work on this already. I'm being hurried up, so I will move on quite quickly. But we have determined through modelling quite a number of potential savings here. We think for our own local health economy about 5 million annualised savings, and that's very conservative. But this is a way that we think we can get to a sustainable health and social care economy. I will be quiet there because you are giving me looks.
Yeah,
so I'll hand over to Aimie. Thank you.
But that's very interesting.
So we'll come back. There are definitely challenges, but I guess one of the reasons we wanted to make sure that you heard this story is we want you to know that it's possible here, right? There's things that we're seeing happening at Airedale that are exciting and possible. But what I want to do next is I want to take you to 2020, right? So I want you to suspend any disbelief you have, or maybe even your beliefs, and let's just listen to a few stories about what it might be like. So, the context of 2020. It'll probably be digital. There'll be big data discussions. Analytics will be part of it. But maybe those words actually get in the way a little bit of what we're talking about, because those all sound like exciting buzzwords and trends. But those trends, I guess, are becoming a reality. I, as an individual, decided to give my data to a company that I trust. Let's call them Google, Facebook for the moment, right? And I trust them because actually not only do they collect my data, not just on health, but on all things, they help me use that data to make decisions about where I want to be and about what I need to do. They won my confidence, and I really trust them. I wear monitors regularly in how I walk around and live my life. And people thought that might have been a bit weird, but then, back in 2013, it became, it was old school to be wearing a rubber band around your wrist to support the war veterans or, health kind of initiatives. So maybe the monitors really aren't that different than anything we've done before. They come in our clothing, not just in our apps like maybe in 2013, but in our clothing, in our jewelry, and actually they're really easy to be part of our everyday life. They actually even come in little stickers that we wear sometimes just to give some extra information. And what they help me do is get a really personalized view of my own health, and that allows me to decide when I need help and how I might integrate with healthcare providers. But let me tell you some stories about the people in my community here in 2020. So, I'm going to click past this. We don't need that right now. As we look at the future, let me introduce you to Charlotte. Charlotte is 25 years old, and she's healthy. And as we look at it, she's waking up on a Tuesday morning. It's about 7 o'clock, and she decides to get out of bed, checks her mobile phone, today's weather, today's stock market prices, and actually her wellness signs. Did she get enough sleep last night? It's calculated there for her based on data that happened in her pajamas or potentially in an app that she was wearing. She notices that she's had low physical activity, so she decides she's going to start her day with a run, right? And so she goes out for a jog, but unfortunately, after she laces up her trainers and heads out with all of her apps, she steps off the curb and she lands on her ankle. Ouch, So as she's limping home, she starts to have a self-diagnostic questionnaire that she's filling out, trying to understand whether the recommendation is to do something locally or to talk to the doctor. And she sees that actually she probably needs to speak to someone. So she logs into her NHS app and she looks for someone who can see her ankle. She notices that there's an A&E option there for a remote consultation. And as she does that, she is looking for a perfect schedule time slot, right? Because she's busy. She's 25 and working and well. And so she selects a time that morning that's convenient for her. So right on time, her phone rings, the video conference starts, and the A&E consultant is there on her iPad, right? And she gets a remote consultation on her ankle. It's swollen, so she's able to show them what that looks like. And the A&E doctor there tells her that she probably needs to wrap that ankle and shows that to her. He has access to her electronic medical record. He can see, many of her signs. He also can give her a prescription because he knows enough about her to be able to do that, and he gets it to the preferred pharmacist. Later, as she is recovering at home and she's picked up these things, she actually accesses the video of that conference that she had with the doctor and reminds herself about how to wrap that ankle, and so she can do it properly. She's really thankful that there's flexibility in the system. Not only did the technology help her to get what she needed, but she was doing it in such an efficient way that she really thinks that actually healthcare is a really attractive option as a career, sees why people picks it, and maybe even thinks of options for herself. So Charlotte finds the experience of 2020 quite exciting. Let's just look at Michael for a second. Michael's another man that lives in my community. He's an 80-year-old pensioner with diabetes. 7 o'clock again on Tuesday morning, Michael's reminded by the wall-mounted tablet in his smart home to test his blood glucose. Michael's had diabetes for 10 years, but he's not feeling great today as he woke up with a fever and he has some trouble breathing. So luckily, Michael's part of a telemedicine program for patients with diabetes, and he rings the 24/7 call center to report his symptoms to a nurse, and he asks for her advice. The nurse suspects that Michael's coming down with pneumonia, and he arranges transport for Michael to head to his closest care center. You'll notice it's a care center because it's actually something that we've decided is appropriate for him, rather than coming into A&E. The nurse will also see Michael's medical records and sees that actually he's been defined as a patient with a patient navigator, somebody who is a more lay person who helps along the way, and she alerts that person. And the patient navigator also gets in touch with Michael's son. Michael's son is worried about his dad and doesn't live very close, but can help to make sure that things are going okay for him. But he can come and meet them at the hospital. The transportation comes because that's been arranged. Michael's son Henry is really relieved to know that these things are being taken care of proactively. He heads to the hospital care center to meet his father, and while he's doing that, he's also reviewing the hospital's performance data and is really happy to know what's going on there. It's very transparent today. While we're looking at that, we also know that this center is a center of excellence around providing this kind of respiratory care. So there's some goodness. You can tap into the right people. They meet at the hospital, and the case manager starts to explain what needs to happen, that he's been diagnosed with pneumonia. And she reassures Michael and Henry that thanks to the single patient record, Michael's treatment regime for his diabetes has already been reviewed and is being followed at the same time as we're treating this condition. She says that the acuity of the condition is relatively low because we got the symptoms and the diagnosis early, so a good process. 4 days later, Michael has recovered enough to be discharged from the care center, and we're really thankful for such a quick delivery and also for the patient navigator. So as we look at this, we can see that both the smart home, the timing, the data has really helped us to manage Michael's condition. And also, we can see that the care was delivered seamlessly. Now, in the space of time, I'm not going to tell you the whole story about the other two, but I'll just hit on some highlights, so I'm going to bring them up. John, who's a different patient, again on the same day, as we look at John, he's 50, right? But he's away from home, and he needs to access care, and he can get a recommendation about care, either from his friends or potentially from a community. And what we get from John is we get the possibility of accessing his clinical records from a different location, right? So John is able to ensure that his provider has the right information about him, but not only that, he can add data to that. He can enter into the dialogue because he's somebody who collects things from his monitors as well. And with one click from that Google, Facebook world, he can allow them to see the things he's been capturing. And that's allowed the doctor to have much more information and help diagnose John and treat him through the process. Now, even in this scenario, we've seen John have to do something that's quite extraordinary, potentially, is that the help that he needed to access wasn't only in the local center of excellence, but it was a global center, and he received surgery from someone through a robotic process with a surgeon that was in a different location. In this case, we used the US as that specialist. So maybe something that is interesting to think about in a more commonplace way. We also put the diagnostic center on the high street, something that we imagine can be possible with different centers of care. The last one here, and again, it's just the doctor's view of the world and what it looks like. And these stories are written out in the paper itself, so I'll let you to read them all. But as we look at that future and we think about what the doctor's world will look like, I think it's also quite important to imagine what it will be like for them. The doctor has access to all of the information that they need to really support the patients. They're able to give diagnostics from not only the tools that they have through their learning and through their situation where they work. They're actually using things like diagnostic Band-Aids, things that they can ask people to put on and gather new information. They're looking at areas where they can use a wider ecosystem of support, the health navigators, the patient navigators. They're using tools and techniques that, again, are available today, but not necessarily as we are using them today, in order to bring some of the most important information to bear very quickly. So I think as we think about what 2020 might look like, and we look back on 2013, there's tremendous hope for possibilities, and yet probably some changes and some thoughts we need to work on and how we might get there. There are 4 things when I was asked in 2020 that we had to tackle, and I guess if I summarize them, there are 4 things to really think about. So the cross-continuum of budget, and Bridget mentioned what she's trying to do around that, and how challenging that can be. And I think it's not a simple equation to solve. Patient engagement and incentives. So what does the patient do in this process? How do they get involved? And how do we incent the right behavior across all of the people involved in the dialogue? I think health system navigation is another one, and that's not just about a patient navigator. That's about where are the centers of excellence? How can we be transparent in knowing what's going on and how we can help people to navigate towards those right centers, whether they're here or around the world. And the last one around this care setting. So where should it happen? And I think Bridget, again, has illustrated very nicely about care in the home, but care in the home, care on the high street, care in different kinds of centers. I think these are all the types of questions. And I think technology can be embedded to help us navigate and make those changes. I want to just ask Kip to enter the conversation. So let me introduce you to Kip. Kip is the head of clinical services at Accenture globally and has seen basically people all around the world. And I know we want to get onto our discussion, but I want him to just start that discussion for us with some comments about how these things resonate around the world.
Well, first off, it's a pleasure to be here. I'm from the United States. I'm a medical doctor. I also have a public health degree in health policy. And so I'm very interested in seeing the relationship between health policy and how it plays out at the bedside. When we began the session today, we saw a survey of questions and how you all had answered them. And I would just begin by saying, you know the answers. You know the challenges that we fundamentally need to transform healthcare. It is going to take new models of care delivery, and 30% of you also said it's going to take patients taking on more accountability and responsibility for the care that they deliver. And then finally, in the last question, the response was that 58% thought that cultural barriers to change were the greatest barriers. And I would tell you that those themes are things that I see all over the world. In the comments that we just heard, what we heard was a great example of how, in the words of the futurist William Gibson, the future is now. It's just not evenly distributed. And Aimie was talking about 2020 scenarios, and we're seeing some of those things, particularly in the United States right now. She talked about IT, but if you noticed, a lot of the examples that she gave were patient-enabling IT, how patients could start to take control, echoing a theme that Bridget had brought up about an integrated medical record and the importance of that. Bridget also used the wonderful expression, patient-orchestrated care, an expression I'm going to steal, by the way. And that theme is also very important in the scenarios that Aimie gave of patient-orchestrated care. We're seeing examples of the combination of technology and patient centricity in the United States. And I want to just give you a couple examples of that. One of them would be Kaiser Permanente, an organization you're all familiar with, and who very famously has invested at least $4 billion in their own integrated electronic patient record. A lot of countries around the world say, oh no, we could never afford to make that kind of an investment. But the outgoing CEO of Kaiser said, because of that investment, I'm saving $5 billion a year in operations. So it's not a question of, can you not invest? It's how can you not invest, because you're going to get that return on investment over time. One of the examples from Kaiser was that the way they modeled it prospectively before they did this implementation was they expected to get a 6% reduction in outpatient visits. And they said that's of great financial benefit to us because it means fewer doctors we need to hire, fewer clinics that we need to bill, fewer support staff. What they found in the Hawaii region was that they were able to reduce visits by 26%, not just 6%, all because of enabling patients to take better care of themselves. The other thing was you give the scenario of an 80-year-old patient, and I wanted to highlight another experience at Kaiser, is that they've set up a personal health record where patients have come in droves, and overwhelmingly, the largest number of visits to that patient portal are from patients over the age of 65. So when we talk about age discrepancies and technology utilization, that's not what we're seeing, at least in California and in healthcare. The one other example that I wanted to give you about new models of patient-centered care delivery comes from an organization that you may not be familiar with, and that's Geisinger Health. And Geisinger Health is sort of Kaiser-like, but it's in coal country in the middle of Pennsylvania. They serve about 2 million patients, largely obese, largely smoking, a lot of diabetes, not a cherry-picked healthy population at all. And they've instituted a patient-centered medical home model of care delivery. A lot of words there, but basically what it means is team-based care, where the physician is acting as the sweeper fullback or the quarterback of the team, coordinating a number of different kinds of care providers to help patients take better care of themselves. What they have found since they've rolled out that model of care delivery, enabled by an integrated electronic medical record, is that they've been able to drop patient hospitalizations by 35%. And furthermore, they've been able to drop readmissions to the hospital by an additional 35%, all because of team-based, technology-enabled care. So the future is now. We are seeing these new models of care delivery. A lot of it has to do with technology, but you also have to overcome the cultural barriers. The one last comment that I want to make about the cultural barriers is the big problem is people who look like me. Physicians are the problems, and it's not entirely unfounded. First of all, we're trained in the scientific method. It's a positivist method that says, prove it to me that it works before I'll adopt it. Our good friend Don Berwick from the Institute for Healthcare Improvement says, we have to stop doing pilot projects. We have to start making bold steps, and I applaud Bridget for the bold steps that they've made at Airedale to try to transform the way that care delivers there. Second thing that we need to overcome with the paternalistic, monolithic approach to healthcare delivery that has marked the way physicians like me have delivered it is we've got to trust a team to participate in that care, that they can deliver the care as well as I can. And then the final thing is that we have to allow that greatly underused resource that is the patient to help inform that care by defining what their wishes are, to use monitoring devices round the clock, to tell us how they want their care to be shaped and the decisions they want over time. Because by so doing, I think we can drive down costs in a much more patient-satisfying way. But it's a great cultural barrier we need to overcome, and that we're just starting to overcome in North America.
Thank you.